Hey guys, welcome back, and we're gonna today cover thyroid agents. So, first subtopic in thyroid that we're gonna talk about is TSH and thyroid replacement. So, TSH is available in a compound called thyrotropin alpha, and it's a synthetic TSH. How it works is that it binds to G protein coupled receptor, increasing the adenyl cyclase and cyclic AMP. It also increases iodine uptake in T4 and T3 synthesis. The only role of synthetic TSH is really the diagnosis of thyroid carcinoma because it induces the thyroid cells to uptake the iodine that's radiolabeled. And if that happens, you can detect which cells are more active, and those would be the cancerous cells. So that is TSH. The more important medication is a replacement of thyroid hormone, and replacement comes into two flavors. The first one is levothyroxine, and the second one is liothyronine. And the only difference is that levothyroxine is the T4 form, and liothyronine is the T3. How it works, um, which is something that is specifically important, is that it binds to a nuclear receptor. So it goes inside of the nucleus and starts working. And that is something test examiners like to examine you on. Use of thyroid replacement is to replace underactive thyroid disease, so hypothyroidism and myxedema coma. And the two flavors, the T4 and the T3, now you're going to ask me which medication is preferred. And the preferred medication is the T4, which is the levothyroxine. And the reason for that is because it has a long half-life, so there's less fluctuation in the drug levels. So that's why it's preferred. And it also causes less side effects. Like tachycardia and cardiac side effects. Liothyronine is used sometimes for situations needing rapid response because it has a short half-life. Uh, we don't usually talk about the dosing for medications, but here I wanted to bring it up because it's an important testing point. So for levothyroxine dosing, you need higher doses for patients that are pregnant and have and or using oral contraceptive use. The reason for that is because thyroxine binds to a protein in the plasma called thyroxine binding globulin. And this globulin or this protein is made in the liver. So if patients are pregnant or if they're using oral contraceptives, estrogen increases the synthesis of this thyroxine binding globulin from the liver. So you need higher doses of levothyroxine. On the contrary, in patients that have hepatic failure, for example, so they have less binding to TBG or thyroxine binding globulin, you need lower doses. Also, patients that are elderly, you need lower doses for them. And patients that have heart disease, you need lower doses for thyroxine for them. And you're going to ask me, why do patients that have heart disease, you need lower doses? And the reason for that is because if we think back to the physiology of levothyroxine or thyroid hormone in general, it actually acts as an inotropic and a chronotropic agent on the heart. So if you think about it, this is a hormone that increases the contractility and increases the heart rate of the cardiac muscle. So if you have a patient with a coronary artery disease or heart failure, uh, then you're going to put extra stress on the heart and you may exacerbate these conditions. So that's why you need lower doses for patients that have heart disease. Some relative contraindications for thyroxine is patients that are on warfarin because it increases the clotting factor catabolism. Um, Patients that are diabetic because it increases insulin needs, and then heart disease patients because of the inotropic and the chronotropic effect, and I've already talked about that. So that's as far as replacing thyroid. Now, if you have a hyperactive thyroid like Graves' disease or if you have thyroid storm, what agents you're going to use? So the biggest kind of two agents that are available to us, or two classes of agents, are the thiamides, and these are medications that are namely methimazole and propylthiouracil, or PTU, or iodine. So let's first talk about methimazole and PTU. So the mechanism of action for both is that they both actually block thyroid peroxidase. So it's the first enzyme that causes um, the iodination um, of thyroxine. So it blocks thyroid. Methimazole causes blocking of thyroid peroxidase. PTU blocks TPO, but it has also the additional property of blocking 5-deiodinase, which is responsible for the peripheral conversion of T4 to T3. So if you have a test question that is asking you, this is a medication that blocks um, TPO and blocks the peripheral conversion of T4 to T3, it would be PTU. Methimazole only blocks TPO or thyroid peroxidase. Use of these medications in Graves' disease, thyroid storm, also hyperthyroidism in pregnancy. The thing about hyperthyroidism in pregnancy, it's a little bit tricky because you have to be careful to not harm the baby. So there's a little bit of strategy to it. In the first trimester, you use PTU because methimazole is teratogenic to the baby. Once the first trimester passes, because we know that this is the period where organogenesis happens, and that's where you have the most effect on the baby. In trimester 2 and 3, you switch to methimazole. So you stop PTU and you switch to methimazole, mainly because PTU have hepatotoxic effects on the mother. Long-term use of PTU can be hepatotoxic. So first trimester is PTU. Second trimester and third trimester, you can use methimazole. Side effects for these medications is methimazole can cause aplastic anemia, and it's a teratogen, as we talked about. And it might be helpful for you to know what exactly does methimazole cause in the fetus, and it causes something called aplasia cutis, and it's when the fetus is, or the baby is born, and there is lack of development of skin on the head of the baby. Google it and you'll see a picture of it. So methimazole is famous for this, and this is something that might show up on exams. PTU causes severe hepatotoxicity, and both agents cause agranulocytosis. I'll give you guys a pop quiz. Do you guys remember what medication cause agranulocytosis and has to be monitored by CBC? Yes, it's clozapine. Clozapine is one of the atypical antipsychotics, very effective, but it causes agranulocytosis. Just wanted to kind of um, remind you of some of the drugs that cause agranulocytosis. Next is iodine. Iodine can be used in as an antithyroid agent, and it can be used in two different strategies. You can give a high iodine dose, and the reason for that is high iodine dose temporarily inhibits, and I think of it of overwhelming the thyroid peroxidase enzyme and T3 and T4 production. That's called the Wolff-Chaikoff effect, and that's something that you have maybe learned about in physiology, but that's what the high iodine dose does. The other thing that you can do with iodine is that you can give radio-labeled iodine, and radio-labeled iodine is toxic to follicular cells, so it goes and kills these cells, so it causes partial or complete destruction of the thyroid gland. Before you can give radio-labeled iodine, you actually need to pre-treat with PTU or methimazole to deplete the stored enzymes prior to killing the cells. Because if you don't, if you just give radio-labeled iodine and you don't pre-treat, all of the cells are going to burst and they're going to release T4 and T3, and it's going to cause a thyroid storm. So that's why we pre-treat with PTU or methimazole. It's contraindicated in pregnancy because you're essentially giving a toxic um, uh, medication to the thyroid. So it's not used in pregnancy. So with that being said, I wanted to kind of give you a summary of thyroid storm treatment because I don't feel we have, a pretty good grasp on it. So I wanted to bring it all in one summary page. And this is high yield for questions because they'll ask you about what exactly what is the role of some of the medications that we use in thyroid storm. So first thing in thyroid storm is that we have a sympathetic nervous system overdrive. So we want to block that because you get the tachycardia, um, the hyperthermia, and all of the sympathetic side effects. So propranolol, which is a non-selective beta blocker, blocks these things. And you also want to block the synthesis of T4 and T3. So you can use the two medications that we talked about, methimazole and PTU. First line is methimazole because it's safer. Second line is PTU. Sometimes, however, PTU is given first because it works a little bit faster, but it's switched later to methimazole. And do you guys know why it's switched to methimazole? Yes, because of the hepatotoxicity that PTU causes. Um, you also want to block the release of T4 and T3, and that's when you give the supersaturated iodine. You can give it as in a potassium form or a sodium form. So that's what the supersaturated iodine. Um, Now you also have T4 that's floating around in the plasma, and you want to block converting it to T3 because that is the active form. So there are two things that you can do. First thing is hydrocortisone, and the second thing is propranolol. Do you guys remember what hydrocortisone is? Yes, it's a corticosteroid, and you can give it in the IV form. Very, very, very important that in addition to blocking the conversion of T4 to T3, hydrocortisone also decreases inflammation. And inflammation is actually what's responsible for the exophthalmos, these kind of like popped out eyes. And this is a question that you'll probably see in New World or some of the other question banks. But hydrocortisone is what is responsible for decreasing inflammation that causes exophthalmos. Propranolol, in addition to blocking the sympathetic nervous system, also blocks peripheral conversion of T4 to T3. So if I want to ask you, what are the three drugs that block the peripheral conversion of T4 to T3? What would be the three drugs? So hydrocortisone is number one, propranolol is number two, and PTU is number three. So these are the three medications. Um, Next is we can remove the circulating T4 and T3, so plasmapheresis, meaning that we pherese out or we remove these hormones from the plasma. Cholestyramine, do you guys remember what cholestyramine is? Yes, it's a cholesterol. It's an anti-cholesterol medication that binds the micelles and binds the cholesterol from the gut. But it's actually non-selective, so it doesn't just bind the cholesterol. What they found is that T4 and T3 goes through the enterohepatic circulation, and giving cholestyramine actually prevents the reabsorption of the T4 and T3, so you can actually eliminate it. So that is one thing that you can do. And the last thing is that you can treat the underlying cause by surgery, thyroid removal. And or radioactive iodine. So this is the summary of thyroid treatment, and I think that this slide is actually pretty important. So this is something that I want you guys to focus on.